Okay, so let's go to the panel. The discussion focus for the panel, like I said, there are 4 themes. The first one is practical AI use cases in Africa. I have a set of questions that I have prepared. I'm going to ask. I think some of the questions you guys might have addressed it, but I want you to expand on what you have presented. So the first one is on practical AI use case in Africa. I'll pose this question to Dr. Egbe. Dr. Egbe, can you share an example where AI performed better than expected in low resource settings? For example, I think you have cited that the AI-enabled microscope for malaria. That was a very an exemplary case study, as you have mentioned. Can you expand on that? And also if there are other examples that you can share.
Sure, Professor. So our team at Bardar University has a project which is entitled Enhancing Malaria Elimination Program through Artificial Intelligence and Digital Health, known as Malaria Aid Project in Amhara region. So this project is aimed at detecting malaria cases in malaria endemic areas, early detection, prevention of transmission, and early treatment protocol for patients with malaria in some areas. So what they did was they registered the whole community or households in Andassa and Arbaminch, I mean Andassa and Chisabay, and whenever there is a suspected case, they will trace it with the mobile application, and they will do analysis using the AI-enhanced microscope, and they will deliver medications. Even treatment response can be monitored using this project. And to add one project, the National TB Detection Project using chest X-ray. There has been a problem in detecting tuberculosis using imaging because we don't have much radiologists in rural settings. Now, using AI-enhanced digital X-rays, you image the patient. If a chest X-ray is labeled as a probable tuberculosis using the AI-enhanced system. So this patient will be sent to a nearby hospital where microbiological confirmation of tuberculosis is made, and the patients will be treated. In addition to that, there are mobile applications which control drug adherence for anti-TB. Previously, the so-called directly observed therapy, where patients were required to visit clinics day in, day out. But nowadays, you can just monitor their adherence using your mobile. So these are 2 of best examples we are implementing now in our setting. Thank you very much.
Thanks again. I will, if other panelists like Dr. Afolabi or Professor Manga or Dr. Egbe, if you can have a case, an example, a success example that you can cite again, I will give you an opportunity. Professor Manga, any example you can cite?
Thank you very much. I think practical use of AI in clinical practice in our own context, especially in Nigeria, is a bit rudimentary. So the honest truth is most of the experiences we have, for me as a clinical microbiologist, I would say except for opinions and also some guides that one would get from the use of AI, but most of them are not as specific. And so we don't have clear regulations or guides with respect to the use of AI in clinical practice. And I give example, for instance, with respect to the antimicrobial resistance, which is where I work with more, is that without us having data antibiogram from hospitals that will supply the baseline information, it is difficult to use AI to predict or utilize for the treatment of infections. For instance, I am aware that in almost 70 to 90% of cases of what we use in treatment of infections in most low risk. I'm just giving example with treatment of infections in the context of the use of AI. And I'm trying to say that, yes, it will provide some guides. We have used it successfully to get some guides based on external experiences. But most of the guides that we get are not based on our local data. So it these kinds of contextual bias from the beginning is a problem. Ability specific, and if anything happens, it becomes a little bit difficult to find out, okay, who is going to be accountable for that. I don't know whether I'm addressing this specifically, but probably these are my thoughts, especially with respect to the use of AI in our own context and in my own context in clinical practice. Thank you.
Thank you very much. Briefly, Dr. Afolabi, if you have one, quick case that you can add. If not, we can continue to the next question.
I don't have any case to add because AI in clinical practice is not existent, I would say.
Perfect.
Practice. Yes.
Thank you. Thank you for
so
that.
So can I just add one example very quickly that was given in our setting? It's Evercare Group. Evercare is present in Nigeria, Kenya, and Pakistan. And they have been using AI to sort of improve the critical care outcomes, So they're using it actually for clinical decision making. And I know that we had him present. He's presenting on. The second is the issue of the voice transcription by Intron. I know they piloted in I think a couple of Nigerian hospitals, I think in radiology and co. But now I think their first sort of major expansion is going to be in South Africa. Sort of in the rural setting. So I do agree, quite a lot of it is in pilot phases, but a couple of places, I think South Africa, and I believe when we heard from Rwanda, from the university in Rwanda, they seem to be using it for surgical care, surgical simulations. But it's still quite pilot, but I think there are a few examples.
Wonderful.
Thanks.
Thank you very much. Okay, let's continue for the sake of time. Now let's go to infrastructure and data limitations. I think the first question goes to Dr. Afolabi. Dr. Afolabi, so lack of connectivity and local compute capacity remains major obstacles. What infrastructure investments are most urgent for enabling AI-driven healthcare at scale, especially in the African context?
The greatest infrastructural developments that African countries, including Nigeria, need is constant regular electricity supply. That has stunted the clinical practice we even have at the moment. Unless hospitals, we have independent power supply, like a few hospitals, government hospitals, maybe Lute in Lagos. We still have problem with regular electricity supply, and without that, there cannot be AI if you don't have electricity supply. There cannot be AI if you do not have good bandwidth connectivity that is wireless. You cannot depend on the cabled connectivity for clinical practice. You need to move on from even computer availability to handheld devices like telephone, which I can access with wireless connectivity. So these are the infrastructure I want us to focus on: electrical supply, handheld devices, wireless internet connectivity, which will be very bandwidth. So anywhere the students are, anywhere the clinician is, can access, can use AI if we are going to get it used eventually. As we are now, earlier on I said it's rudimentary. So the Evercare that my colleague mentioned, in private practice, whatever is not in the public sector is of no benefit to us in Africa. Until we get AI to power healthcare in the public sector, to get to the people who need healthcare at the lower level, we're not there yet. So it is good that pilot studies are being done at those private hospitals. So we need electricity supply, bandwidth connectivity, and handheld devices, which each clinician, medical student, resident doctors can have to access whatever they want to use AI for, either clinical decision making.
Okay.
Surgery. And so connectivity, electricity, and handheld devices are the infrastructures that we need in Africa for now.
Okay.
Thank you.
Okay. Okay, thanks. Thank you. So I thought you stopped there. Okay, great. Now, the same question to Dr. Manga, but I will also add this. In settings where infrastructure cannot quickly improve, how can AI systems be adapted to operate in low bandwidth or device limited environment? I mean, there are some examples that we can cite, but can you enlighten us on that, Dr. Manga, Professor Manga?
Yeah, I think not just to repeat what Dr. Afolabi has said, of course, it's a general problem in the context of what is referred to as digital poverty. We have problem with electricity, we have problem with internet, we have problem with the equipment or the computer, the other gadgets to use. I think this is a general problem, of course. But going to the second component of the question you posed, which is despite the challenges, how do we try to address this, or how do we use AI? I feel we are talking about AI in this context in real time. Records, electronic medical record system, and also many of the hospitals going paperless. Like my own hospital now has been paperless for some years, and to an extent, of course, with initial challenges that are problems, but with significant improvements that you can now communicate with your colleagues from anywhere within the hospital, and you can request for investigations and follow them up and make comments still while you are online in such context. So this is something that is happening, and I feel it is possible that we embrace and make the best use of whatever is available while we try to improve. Thank you very much. Over.
Thank you very much. So for the sake of time, I think we have two more subtopics. So let's go there, and then maybe we'll take a couple of questions from the audience. So the third subsection that we have for this panel is the ethical consideration stuff that I think Dr. Egbe has addressed in her presentation. But I'll ask this question first to Dr. Afolabi and then Dr. Egbe. So weak regulatory systems in many African countries raise concerns about errors, bias, and patient harm. What regulatory frameworks are needed to responsibly deploy AI in health settings in Africa? Just your thoughts, Dr. Afolabi, and Dr. Egbe will follow with that, and I'll have another question for you.
Okay, so cannot build something on nothing. So what regulatory system do we have currently without AI? The Medical and Dental Council of Nigeria is the regulatory body in Nigeria for research. The National Health Records Ethical Committee and also the local IRBs are the assistants. And for service, each hospital has clinical governance. For example, as a unit or department, we have what we describe as a clinical meeting, mortality morbidity meeting, where we review mortality and morbidities. So we can start from there. How do we deploy AI to enhance the use, the working system we have on ground? So that would be, you have to consider the ethics of introducing AI into all these existing practices, ethics about justice, beneficence, no malfeasance, confidentiality, and all that we know about ethics. So we need to consider all these as we introduce AI. AI can help in data collection, data recording, but sharing of data, America is very careful about data. The HIPAA, they also even in Nigeria, our case note, we say that this case note should not be carried around by the patient, try to get information, though that can be open to debate. It's the patient's information, electronic medical record that was mentioned earlier on. Yes, it's good. These are the basic things we have at the moment. How we're going to deploy AI into this, with considering the ethical education is very important for us in Africa. And we should not shy away from it. We should have regulatory system, regulatory body in place that will monitor the use of AI. Human beings, AI probably has a good side to it, but human imagination, human mind is so elastic that it can go to the other side of evil. And so we need to monitor, which is where ethics come in. So we have to have body who will monitor the use of AI, whether in research, whether in clinical services, or whether in training of our students. Currently, for example, there is Turnitin for checking whether our students are plagiarizing or not. There's also AI-powered system to help us check whether students are using AI to write up their research. So there are rooms for AI to be used, but the ethical consideration is so important. Somebody asked the question earlier on, if you use AI for clinical decision-making and there's medical error, and the patient or the relation sue you, who is accountable for it? Is it AI or the physician? For me, the physician who chooses to deploy AI in managing his patients is accountable, responsible for the patient's clinical outcome. You cannot blame your instrument. You should blame whoever uses the instrument. If you use AI for clinical decision making and things go wrong, that physician takes responsibility, and the medical council or even the local hospital clinical governance should look into that very well. Let everybody want to use AI know that there are consequences. I always say that choices have consequences. So choose right always. I'd rather choose between AI and other existing things, know the consequences on the life of my patient, for example. So we should bear this in mind. The ultimate bottom line is the golden rule: do unto others what you want others to do unto you. Me as a physician, I like this to be applied to me if I become a patient, for example. So it's very important. At the same time, I have the philosophy of we can do this. You cannot say you cannot do this. You must have philosophy of it can be done, it can be achieved if properly guided ethically. So I will encourage us to look into the ethical components as much as we do at the moment, even more. Regulatory component that will protect the patient. The patient should be at the center of our care ethically. It is not about what facility any hospital is using. What is the patient outcome? Has there been any change in patient outcome since introduced AI in clinical decision making? For example, if there is a worse outcome, then we stop it. Let's go back to our human intelligence, which we have been using. AI is supposed to assist us anyway. It's artificial, and there's no way it can beat human intelligence. So AI can be used, but ethical consideration is important because the patient-centered care is what is important. The outcome for the patient. What will be the outcome for me if I are a patient and AI is applied to my care or research, decision making, and all that? We should not forget our healthcare system we are talking about as a tripod of research, training, and clinical services. The research conducts drives the training of our students and resident doctor. The research conducts the outcome of our researches, also improves our clinical practice so that we'll not be practicing what was done in the 80s, in the 90s, again. So research, AI can be applied in research, ethically speaking, so they can get good outcome of research that will guide our training of our students, the future surgeons, the future physicians, who will then go and practice on the field to the patient. And AI also, ethical use of AI in monitoring disease outbreak. We have Lassa fever in my part of the country at the moment. How can we apply AI to even predict that Lassa fever comes in a particular month of the year? Lassa fever spreads this particular. We can deploy AI ethically in that. Disease surveillance and monitoring of diseases. So ethics is vital. It's very important so that we not go back to the olden days where things were bad. Thank you very much.
Thank you very much again. Okay, let's continue with that theme, Dr. Egbe. So how should developing countries balance the adoption of AI tools with safeguards for privacy, consent, and data protection? So you can also, chime in on the first question, Dr. Egbe. Dr. Egbe, are you with us? Dr. Egbe? Okay. Maybe we lost her. Who can take this question? Anybody, Dr. Gabao or, Dr. Manga? If you can chime in on this one. I can repeat the question. How should developing countries balance the adoption of AI tools with safeguards from privacy, consent, and data protection?
Okay, let me make some efforts. I think everything revolves around contextualization and being sensitive in terms of ethics, cultural acceptability of whatever we're going to use. So the basic principle of do no harm, the basic principle of beneficence, non-malfeasance, which have been there in the context of medical ethics, and also the aspects to do with morality and many others are there. I think those ones are universal principles that should be deployed. And the most important thing is for countries that currently do not have any consideration, any regulation in the context of balancing the use of AI in clinical practice, in education, and others, to come up with one that is contextualized and also reflects their own local realities and peculiarities. If we're able to have that, then of course it is something that will now serve as a platform on which we're going to build on all the subsequent activities and interventions that will come in. So in that regard, I think the best approach is to have guidelines, to have regulations that incorporates and reflects the use of AI, because AI has become a reality and is almost inevitable. That for me, I feel if one is thinking of AI as artificial in the present day, then he might himself also be artificial, because it is artificial, but it has become natural in the context of its applications. So the best thing is to come up with guidelines, to come up with regulations, and to contextualize and incorporate all the aspects of AI in our clinical practice, also in our educational activities, in our curricula, in our examinations, assessments, and everything, so that when whatever we do and whenever we do it, it will reflect something that we have some universal language that can be utilized, and some applications that can be reflected in all our activities in different settings, whether clinical, whether educational. So I feel if we do that in low resource settings and make it to reflect our own realities and peculiarities, probably that will be of great benefit, and that will form the platform on which we can view and continuously change and improve in future. Thank you. Over.
Thank you very much. I think I see Dr. Egbe. Dr. Egbe, are you back?
Okay. Yes, I am. Sorry. On the issue of privacy, content, and data protection, I think there are two levels. There is what the country does and what you do at your institution. And I don't think, for example, many countries,
Yeah, you are again breaking, Dr. Egbe. I really am sorry to say that. You are breaking. We cannot hear you at all. Sorry about that. So, sorry, if you can fix that again, that will be great, because I see a lot of questions in the chat. So if I could, address a couple, that will be good. But let's finish the panel first. I think the last topic, maybe for the sake of time, is the capacity building and workforce development. I think the first one is, how is AI reshaping the role of health workers in Africa, from community health promotions to physicians? And what new competencies will be required? Maybe Dr. Gabao, can you chime in on this one a little, Dr. Gabao? Are you there, Dr. Gabao? Okay,
Yes,
so
Prof. I'm here.
Oh, are you there? Okay. So this is about the workforce. What competencies will be required, for AI adoption and because AI is reshaping the role of health workers in countries like Ethiopia, Nigeria, and all that kind of stuff. So can you tell us your perspective on that?
So, in this perspective, the first thing to understand, I think, is to know that artificial intelligence can be trained itself. So we can train artificial intelligence to contextualize it to our environment, our setting, and what it takes is to train few competent individuals to a global or a world-class AI training systems. After that, we can contextualize artificial intelligence, and we can lower it to, like offline systems, and a bit like low resource consuming systems can be implemented once we contextualize it. To add on the data security, I think it is also an opportunity for developing countries, because previously their data system using the AMR systems, it was not secure, threatening their national sovereignty. So nowadays, if a nation can control its own data using an AI-enabled AMR system, you can secure your data security or your national sovereignty over medical data. Thank you very much.
Thanks for that.
Okay.
Let me.
Sorry. Can you hear
Yeah.
me now? Hello,
Okay.
can you hear me?
I can hear you. Yes. So
Okay.
maybe
So what?
maybe you can try, instead of the first one, if you can talk about the workforce capacity
Okay.
building, will be a good one.
Okay.
So focus on that.
Okay.
Okay. Thank you. Thank you.
Okay. Thank you. But can let's do first. I was going to say one for the workforce capacity building. I think in many countries we should look at what happened in the financial sector, and that was what I was going to say about data and privacy. Many countries have data and privacy laws. I mean, in Nigeria, they just um, expanded it to include healthcare. But many countries have data and privacy laws for finance or the financial environment, many of them which are applicable to healthcare. And basically, the institutions should have a governance structure while you're waiting for. And when you talk about capacity building, I think we had mentioned it earlier. I think one of the key issues across all folks, you need to have sort of AI literacy, and I also think that you should encourage more medical folks to actually start thinking about coding or developing, urgent AI tools, because they understand. We had somebody on a platform who was talking about anesthesiology, a very nice program developed in Spain by an anesthesiologist who was also a mathematician from MIT. And based on that, they were able to use anesthesia data to do sort of predictive analysis. So, in terms of developing the workforce, there are two sets. You need to develop everybody to be AI literacy, and it should be included in the curriculum and that kind of thing. But the second, also to develop the kind of folks from Africa who can also design tools like Toby and all those other people, or of who can design tools that are very specific, that answer medical problems. You don't want things driven by technologies because they often do not answer the problems that actual providers have. So just to say, I think there are two things. I mean, the government needs to create the environment so that it works, but curriculum change for all types of healthcare professionals so that they're all AI literate, both in literacy, understanding ethics and privacy and those type of issues. And then the second is really, like I said, really having people who can design the next types of tools that are applicable and work best in the African environment based on mobile phones, lack of energy, and all the issues that people talked about. And then the third, I was going to say, about 15 years, no, more than that, 20 something years ago, one of the first technology things I joined was Mayo. Mayo Clinic put together an advisory council looking at social media in healthcare. And that was in like in 2010, something like that. extremely early before other folks start to do that. So I think institutions, as you're thinking about how to use AI and develop AI, put together committees and council, bring together external people and internal people so you can take the ideas forward. And I really would really give BDU as an example, as a way to really customize this to meet your environment, but taking into advantage external information. Thanks very much.
Thanks for that. Thanks, Dr. Egbe. Okay, the last question from my part is for Professor Manga. Professor Manga, given the existing shortages and limited training resources, what strategies could help countries develop an AI-skilled workforce, especially on the health sector?
Yeah, thank you very much. I think from the perspective of education, for me, I would say integrating it at all stages and being intentional at the phases in which we are and how we develop. So integrating the use of AI in undergraduate training or pre-service training, and also ensuring that that integrated aspect is built upon and sustained after graduation and even when people are serving. Probably that is the first stage. Aside all the other discussions with respect to the regulations, the guidelines, and also trying to integrate it into the real practice, making sure that our curricula from the beginning when they are developed for both undergraduate and postgraduate training reflects and also understands the importance and value of AI, and also integrates that training and utilization of AI concurrently, both for the undergraduate and the postgraduate training. And also in the clinical practice, for instance, especially when we are training students to have the AI integrated into the activities such that we'll have a way of assessing them, we'll have a way of evaluating, and also integrating AI into or having some mannequins and skills acquisition approaches that will also be reflecting the realities of availability of AI and how it is being utilized. So I feel if we're able to do that across all these pairs, across all the stages, and also conceptualize the integration of that knowledge into practice, I feel in future we'll have AI reflecting in all that we do, and it makes the practice more efficient, and it makes our productivity far more optimum than what we have now. Thank you.
Thank you very much, everybody. I see lots of questions in the chat, so I don't think we have time to address that. My suggestion is, I think, for the organizers to, copy all those questions. They could be agenda topics for future similar seminars. So with that, I think I'd like to close this panel. Thank you all for this engaging and thoughtful discussion. Today's panel highlighted both the promise of AI to strengthen healthcare delivery in developing countries and the importance of implementing these tools responsibly, equitably, and at scale. For me, a key takeaway is that technology alone is not enough. Impact depends on inclusive design, strong policy, and collaboration across disciplines and communities. So thank you to our panelists, organizers, and audience. And I hope we continue working together to ensure AI continues to be more resilient and equitable, create equitable health system for all. Thank you again for listening. I'll give the floor back to Dr. Inauga.